Hello, everybody. I'd like to talk to you about the importance of omega-3 fatty acids in malnourished, critically ill patients. These are my conflicts. When I use the term omega-3 fatty acids today, I'm really talking about two omega-3 fatty acids, EPA and DHA, eicosapentaenoic acid and docosahexaenoic acid. These are the main bioactive omega-3 fatty acids. EPA and DHA have unique structures. They're very long chain and highly unsaturated. So EPA has 20 carbons and 5 double bonds in its chain, and DHA has 22 carbons and 6 double bonds. These structural features give EPA and DHA unique physical properties. They also give EPA and DHA unique functional properties. And in fact, the physical properties are linked to the functional properties. This scheme shows an outline how EPA and DHA influence how cells work. So when we have increased exposure to EPA and DHA, they're easily incorporated into cell membranes. And because of their unique structural properties, their long chain and high number of double bonds, they influence the structure of the membrane and the physical properties of the membrane. They also influence the environment in which membrane proteins function. These are proteins like receptors, transporters, ion channels, and so on. So through this increased EPA and DHA content of the membrane and the alterations in membrane physical properties and membrane structure, signals generated from the membrane are altered when EPA and DHA are present. Some of these signals influence gene expression and protein production. So we have a mechanism here where increased EPA and DHA in the membrane influences intracellular signaling pathways, and in turn, they influence how cells and tissues respond to signals, electrical signals, chemical signals, hormonal signals, immunological signals, and so on. This scheme shows in a little bit more detail that sort of mechanism. So EPA and DHA are incorporated into membrane lipids, altering the physical nature of the membrane, and also influencing the assembly of what are called lipid rafts. These are actually signaling platforms where proteins come together in response to cellular stimulation. There are also some G protein coupled receptors through which omega-3 fatty acids, particularly DHA, act. So in other words, DHA and EPA as well have hormone-like actions on some cells. When you have more EPA and DHA in the cell membrane, cells produce lower amounts of some of the lipid second messengers, things like prostaglandins and leukotrienes. So there's lots going on in the membrane of cells enriched with EPA and DHA, and all of these membrane-mediated activities influence signaling, altering cellular responses, gene expression, cell activation, and so on. This influences actually what the cells are doing, so the physiology, and that impacts on health, disease risk, disease severity, and clinical outcome. So through these mechanisms, EPA and DHA influence visual and cognitive function, metabolism, inflammation and immunity, oxidative stress, blood coagulation, and the function of many organs, including the heart, liver, lung, and muscle, wound healing, and lots of other things as well. So the effects of EPA and DHA are widespread throughout the body and occur right through the life course. So again, to put it simply, increased EPA and DHA exposure through the diet or through nutrition support alters the fatty acid composition of cells, improving cell and tissue phenotype, impacting on health and clinical outcome. One of the real targets for EPA and DHA is inflammation. And EPA and DHA have multiple anti-inflammatory mechanisms. If you want to read more about the anti-inflammatory actions of EPA and DHA, you can look at this review. This figure is taken from the review, again, just outlining the mechanisms of action. So I've told you they're incorporated into cell membranes. They actually decrease the amount of arachidonic acid that's there as well. This reduces the production of pro-inflammatory eicosanoids, like prostaglandin E2, prostaglandin D2, and the 4-series leukotrienes. I've mentioned already that they alter raft assembly, and with respect to inflammation, this is really important in reducing the response to classic inflammatory stimuli like bacterial endotoxin or lipopolysaccharide. They suppress NF-kappa B activation, which means they reduce the expression of genes encoding many of the inflammatory cytokines, chemokines, and so on. So multiple anti-inflammatory mechanisms. Now, in the last 20 years, people have got interested in the different phases of inflammation. So when we talk about prostaglandins, leukotrienes, cytokines, chemokines, we're really talking about the initiation and propagation of inflammation. But inflammation also resolves. So there's a natural way of turning off inflammation. And researchers got interested in the chemicals that were present during the resolution phase of inflammation. And when they went looking, they were able to identify new families of lipid mediators, and they called these families resolvins, protectins, and maressins. And together, the resolvins, protectins, and maressins are called specialized pro-resolution mediators, or SPMs. Now, it turns out EPA and DHA are actually the substrates to produce the resolvins, protectins, and maressins. So EPA produces E-series resolvins, DHA produces D-series resolvins, protectins, and maressins. So as well as their anti-inflammatory actions, EPA and DHA also trigger resolution of inflammation through the generation of SPMs. So the way people look at this now is you have an inflammatory trigger, tissue injury, infection, metabolic stress, oxidative stress. They initiate acute inflammation, and physiologically, acute inflammation should resolve. And these omega-3 derived SPMs are really important in the resolution. If that doesn't happen, the acute inflammation becomes chronic, and chronic inflammation is pathological, increasing morbidity and even mortality. Now, experiments in model systems, animal models of inflammation, for example, have shown that the application of SPMs can resolve chronic inflammation. So the idea is a lack of omega-3s leads to a lack of these pro-resolving mediators, and that leads to failure of acute inflammation to resolve. So what this means is there are many targets for EPA and DHA because many conditions involve inflammation. So we have the chronic inflammatory diseases, many cancers, age-related non-communicable diseases, conditions of altered body composition, and then in hospitalized patients, major surgery, critical illness and trauma, and the adverse response to infection. And these latter three, of course, are associated in what is now termed the cytokine storm. So there are many targets, many applications for these anti-inflammatory and pro-resolving actions of EPA and DHA. Now, I think this is really important in, for example, critical illness or following major surgery, where you have an insult that triggers inflammation. In some patients, this can become overwhelming. This is the cytokine storm. And this overwhelming inflammation is associated with immune paralysis. Now, the inflammation itself can lead to tissue injury and organ failure. And of course, the immune paralysis results in inability to control infections. So this condition results in poor outcome, increased morbidity, and even mortality. Now, we can study this in models like endotoxemia. So these are two graphs from studies in laboratory animals, where the animals were given either vegetable oil, rich in omega-6 fatty acids, or fish oil, rich in EPA and DHA. And on the left, the animals were given a lethal dose of lipopolysaccharide, and you see they died in the vegetable oil group over 10 hours, whereas the fish oil group had a survival advantage. So fish oil stops mortality in experimental endotoxemia. On the right is a study we did in mice, feeding vegetable oil or fish oil, and then giving a sub-lethal dose of lipopolysaccharide. Then we measured the inflammatory cytokines in the blood of those animals over a period of time. And these are the peak concentrations of TNF, IL-1, and IL-6. and you see the inflammatory burden, the inflammatory storm, if you like, the cytokine storm, is reduced with fish oil feeding compared to vegetable oil feeding. And I think this reduction in inflammation is what's responsible for the survival advantage of fish oil in this model. So going back to the patient, we could use EPA and DHA to control overwhelming inflammation, to control immune paralysis, and that could result in improved patient outcome. So this is a study I was involved in, carried out in Portugal. Septic patients in the ICU who were intolerant of enteral nutrition received total parenteral nutrition over 5 days, with the lipid coming from a mixture of soybean oil and medium chain triglycerides, or soybean oil, medium chain triglycerides, and fish oil. On the left, we have airway function, respiratory function, showing that respiratory function was better at day 6 in the patients receiving fish oil than control. And then on the right, we have hospital length of stay, which was reduced quite remarkably with fish oil compared to control. That's an example of one study. There have been quite a few studies, and these have been subject to quite a number of systematic reviews and meta-analyses. This is the systematic review and meta-analysis by Manzanares, published in Critical Care in 2015. And they concluded that in critically ill patients, fish oil containing lipid emulsions, so this is parenteral nutrition, IV fish oil, may be associated with reduction in infections, reduction in duration of ventilation, and reduction in hospital length of stay. So that's a pretty, I think, positive finding from that meta-analysis of the studies in critically ill patients. Last year, there was a bigger meta-analysis of intravenous fish oil lipid emulsions in hospitalized adult patients. So this included critically ill patients, but also patients who had undergone major surgery, for example. And what the meta-analysis showed was that use of fish oil in intravenous nutrition compared to lipids not containing fish oil reduced the risk of infections, ICU stay, hospital stay, and the risk of developing sepsis. You see the number of trials here, you see the effect of fish oil compared to control, and you see the statistical significance of the effect. So a pretty good indication from meta-analysis that omega-3 fatty acids have benefits as far as clinical outcomes are concerned. And I think these benefits relate in part to effects on inflammation and immunity, but also on function of other tissues. So the meta-analyses support parenteral fish oil in hospitalized adult patients, including those with critical illness. The Aspen guidelines on this are shown on the slide here. So this is the 2019 Aspen guideline on clinical nutrition in the ICU. It says where patients are receiving parenteral nutrition, it should be enriched with EPA and DHA, or can be enriched with EPA and DHA. So I think the guideline supports what the meta-analyses and some of the individual studies are showing. What about enteral nutrition in fish oil? So fish oil is a component of many enteral formulas. Often these are called immuno-enhancing formulas or immunonutrition. Of course, these formulas also contain other bioactives, arginine, some of them contain glutamine, antioxidants, RNA, and so on. So the effects can't be ascribed specifically to fish oil. Maybe it's the mix of the bioactives, maybe it's the other bioactives, or maybe it is actually the fish oil that's the key bioactive here. This is a meta-analysis we published of fish oil enriched formulas in acute respiratory distress syndrome. And you see the clinical outcomes here. So these are the outcomes, the effect size with the 95% confidence interval, and the statistical significance. And you see all of these statistically significant benefits of including fish oil compared with the comparator. So with EPA and DHA, there's better lung function, fewer failing organs, shorter stay in the ICU, so patients must be getting better, and less mortality at 28 days. So what I've told you is EPA and DHA are bioactive, and they act through multiple mechanisms to affect cell and tissue function. They reduce inflammation and promote resolution, so there are multiple targets. I then went on to explain how overzealous inflammation impairs patient outcome, and then to talk about individual studies and meta-analyses around parenteral and enteral application of fish oil. So parenteral fish oil is safe in adult patients and has clinical benefits in critically ill patients, as supported by meta-analyses, and also in major surgery. Enteral fish oil, as part of formulas with other bioactives, is safe in adult patients and may have clinical benefit, including those with critical illness. And I showed you the meta-analysis in ARDS. So if we think about what's going on here and the importance of nutrition in determining pathophysiology and patient outcome. So nutritional inadequacy, malnutrition, leads to lots of declines in the body. But what I'm showing here is it promotes inflammation and oxidative stress, it weakens immunity, and it results in loss of lean mass. Of course, weakened immunity results in infection and inability to control infection. That's bad news. The loss of lean mass, the inflammation and oxidative stress result in functional decline. I think this amplifies the nutritional inadequacy, and of course the functional decline results in poor outcome. If we layer an insult, so infection, major surgery, some injury or other, that really magnifies the effect of the nutritional inadequacy. So it promotes inflammation, weakens immunity, opens the door to infection, drives loss of lean mass. And of course, the insult magnifies the nutritional inadequacy because people are unable to eat, they become intolerant of artificial nutrition support, and so on. And what I put to you is omega-3 fatty acids can have a role in mitigating the effects of insults. They reduce inflammation and oxidative stress, they promote immunity, and in fact, they reduce the loss of lean mass in the face of surgical insults, bed rest, and so on. So I think there's a real role for the application of omega-3 fatty acids in malnourished patients, and this will result, I think, in improved patient outcome. Thanks very much for your attention.